Hello, and welcome back to Falcon Physician Review's Anatomy component. In Section 18, we'll focus on medical imaging. Medical imaging has undoubtedly been one of the biggest advancements to medicine in the last 100 years. That fact has started to be reflected not only in the practice of medicine, but also in board exams. Imaging is important in almost every specialty, and I'm sure you'll see more images throughout this course. In reviewing the types of anatomy questions, I noticed that they were often about relationships and normal anatomy. So for this reason, and to ensure that everyone has a firm grasp on imaging, I'll focus on normal anatomy with some interspersed pathological images. Let's get started. Wilhelm Röntgen, the first Nobel Prize winner in 1901, came up with the first X-rays, and he took a picture of his wife and her hand to win that first Nobel Prize. And it's been important ever since. Now, the typical X-ray will penetrate through tissues, and if it does so, it's called radiolucent. And if X-rays don't penetrate, it's called radiopaque or radiodense. Films tended to have silver bromide. However, now, in the US at least, almost everywhere is using digital direct. So they don't use films anymore. If they are still using films, remember that its unexposed film is white, not black. Here you can see Wilhelm and the first X-ray image that he took to win the Nobel Prize. One of the things that's important about imaging is that there are three different densities. There are bone densities, water densities, and air densities. Bone densities will appear white because of their opacity. Water densities will be grayscale with blood vessels, soft tissues, and fluid accumulations. And air densities will appear black. Lungs, paranasal sinuses, or very small levels of fluid. Plain film images produce singular, superimposed two-dimensional images of three-dimensional structures, which can sometimes be confusing. In essence, they have a summation of a shadow, or a shadowgram, which acquires a complete understanding of the human body in order to be fully understanding what's happening in a three-dimensional image. Here we've marked an air density, a water or fluid density of soft tissues, and the bone density of the acetabulum. Shadowing is an important concept that you should make sure you understand for trying to interpret what's happening in film. Because shadowing can not only introduce artifacts to films, it can also be used to understand the positioning of what's happening. If you have an object that's further from the pickup film or the digital pickup detector, the X-rays will cast shadows just like a flashlight. If the object is closer to the film, they're sharper and crisper, and then closer to their natural size. If you're looking at X-rays themselves, they'll appear sharper and closer when it's the distance between the source ray and the film increase, and the distance between the object and the X-ray film decreases. Here you can see an AP of a 76-year-old male or female. Which way could you tell whether this was male or female? Well, in the inferior aspect you can see a breast shadow, which would reveal that this was a female. You can also see a couple more things on this film. The three different densities should be plainly visible. Is there shadowing? Well, there is some shadowing if you look at the sternal end of the clavicle. It's slightly distended and looks larger than it should. The spinous processes are actually a little bit crisper, especially in the neck region where you can see them through the lucency of the trachea. You can see a couple electron-dense structures as well, which would be this mitral star valve, an old mechanical valve replacement valve. And you can see another structure, which are metal. One, they don't look any different at this point, so you always need a lateral view to go with this image so that you can get a clear sense of what's happening. If you look at that, now you can see that the porcine valve, what was in the center, is actually inside the body, and it's a different type of valve, whereas those two leads were sitting on the surface of the body. Now you can get a clearer view of those sternal wires that are involved as well. remembering the A, B, C, D's of imaging can be helpful. First of all, A for alignment, as well as age of the patient, which will play into your interpretation. B stands for bone density, which you should have relative to both age, alignment, and body. C, the contour, which means follow the lines so you don't get lost or distracted by overlaying densities. D, the distribution. Is something distributing where it should be, or is there something else in the way? And then finally the S, which stands for soft tissue, or even the sex of the patient, is always going to be important in interpreting the radiographs. Moving on to computer tomography. The computed tomography used to be called the CAT scans, and still often is, but it used to stand for axial with the A, and since they can now manipulate that computer information in any angle, they've cut back to calling it computed tomography instead of axial. The computers will recombine the data into multiple planes using algorithms. But this is still old technology in that it uses X-ray technology and ionizing radiation. It actually takes slices of the body instead of condensing it down from 2 dimensions to 3 dimensions. So there's no superimposition, or at least it's much narrower superimposition. The size of the slices can also be altered at this point at 0.625 millimeters and on up. The different types of CTs, whether it's a 4-slice, 8-slice, 16-slice, 64-slice, and even some of the newer ones are moving up to 128 slices, that's going to be different technologies in that it will take 4 simultaneous slices if it's a 4-slice and 64 simultaneous slices if it's a 64-slice. The pluses and minuses of these is that the more slices you have, the more ionizing radiation that you're exposed to. But the faster the image is acquired. So when you're working in a complex 3-dimensional world where you're having a moving heart that moves not only in one direction but all 3 directions, and you're trying to image the lumen of a very small vessel and see whether it's 60% or 90% occluded, you have to have high definition images that are grabbed in real time, and temporal distractions of the capture of that can be problematic for interpretation. So they typically use the larger slice machines for fast acquisition of images, such as in thoracic imaging. 16 slice is common in regular hospital now. So since it uses ionizing radiation and X-ray technology, you see the same kinds of densities, but you see less imposition of overlying structures, so there's better clarity since you're using a slice. Some of the advantages of CT is that it will produce anatomical cross-sections which can be manipulated into any plane as well, which will help facilitate precise diagnosis. It gets rid of all the superimposing shadows and the complexity of trying to interpret a 3-dimensional world in a 2-dimensional film. And it's fairly low cost still, although it depends on where you are, where this price will be higher or lower from that. And it's quite fast because of its relative cheap technology compared to some of the newer technologies. It produces high quality images of both soft tissue and bone, and it's further enhanced by things like contrast media to visualize vessels or even the GI tract. And it really is a great diagnostic tool for clinical problems in the chest and abdomen because of what we mentioned earlier with that acquisition speed they now have the capacity to do. It's highly manipulable data, but also it's data and it is manipulated. So it's difficult sometimes to know that there's computer-based changes that are going through this data based on whichever algorithm you're running it through. Some of the disadvantages of CT is that it uses ionizing radiation. In fact, it uses a lot more ionizing radiation than a simple plain film, anywhere from 10 to 100 times more radiation, depending on the number of slices and how much of your body's exposed, etc., etc. So these are serious patient risk assumptions that we need to make clear to them, and it's also a moral and ethical issue, because if we don't inform patients of why there's some inherent risk with this kind of technology and we're only doing them because we don't want to get sued, a lot of times you're actually exposing someone to harm, and that's of course against our Hippocratic oath. And they cannot be used on pregnant patients, although this is in dire straits. Certainly they will be used on pregnant patients, but that exposure to an infant is going to have a longer deleterious effect to an infant than it would to somebody that was already 80 years old. And the fact that it uses volume averaging is really discussing the idea that it's taking data and digitally manipulating it through algorithms so that it's not actually real information like it used to be with a plain film. Contraindications. Pregnancy, we've discussed. Patients with unstable vital signs. There's a law in the hospital that would basically say that if somebody's going to crash, they'll do it once you get them on the CT or MRI table. Obese patients, because they have trouble fitting into the narrow tubes of the CT scanner sometimes. Metal implants, which are not as bad of a problem as they are with an MRI, but they do cause scattering and distortion effects. And of course, patients with allergic reactions to some of the dyes could be a problem as well, so you have to make sure before doing a dye contrast study that you check those things. Angiography uses X-ray technologies as well. Here you can see a femoral arteriogram, and this is basically going to be used for lighting up the vessels in relationship to the bony structures around it. However, because of the bony overlay, sometimes the bones get in the way and you don't get a clear picture of the vessels, or you don't get a clear picture because you've superimposed 3 dimensions down into 2. Here's the internal carotid arteriogram. You can see the architecture of the brain and if there's any bleeding or accumulations in here, so it's good for that. Another form of angiography is using digital subtraction. Digital subtraction will take a picture of the regular architecture of the bone prior to contrast media, take another one after the introduction of a media, and then subtract the two so that it reduces the bony architecture around the area. This can be both good and bad. It lets you see the detail of the vessels much clearer, but it also has a more difficult time for orientation. This one is adding a second type of technology in that it's using a fluoroscope or a C-arm. And the C-arm is going to be almost like a cinemagraphic angiography, so it's real time and has a temporal component to it like a movie. The good thing about using the subtraction is that you can use less dye and still get good contrast. In an MRI, the contrast media is going to be gadolinium, and in a plain film you tend to use iodine. When you move into MRI, there are 2 types of MRI. There's a T1 weighted MRI, whereas you can see in this one the white fat behind the orbit shows up and then fluids show up black. Notice how there's really nice definition of the grayscale soft tissues. When you look at a T2 film or MRI, you can now see that there's a contrast change in that the dark fat in T2 and white fluids show up in a T2. One way to remember this is a little memory aid known as H2O. H2O, of course, is the symbol for water, so what this reminds you of is water in the 2 of a T2 film is O, which stands for opaque. So water is opaque in T2 films. What are some of the advantages of MRI, which uses high field magnetic forces to align the hydrogen basically in water, and by flipping this on and off it can look at the changes of the alignment of that water versus the unaligned water. and then it can pick up a signal from that, essentially like a big radio signal, and then produce a grayscale image from it. This does not use ionizing radiation, so it's thought to be completely safe for the patient. It produces very high quality images of soft tissue, and it produces customized sections of anatomy because, again, it can be manipulated in any of the digital planes. It's been an established technique for longer than CTs have been around, but it's been available in the hospitals for a shorter period of time. And it's great for soft tissue with the brain and the spinal cord because it will take, again, slice technologies and have very high resolution of soft tissues. What are some of the disadvantages? It's much more expensive and time-consuming than a CT. It cannot be performed on patients with any implants or magnetized or iron-containing metals. Can't be done easily when patients are on machines such as respirators because of the time it takes to do it and because those often have metal in them. And it certainly isn't available in every hospital. So you can actually take a long time to get people an MRI, where you have to really be sure that the wait is worth the time consumption. Some of the contraindications of MRI are essentially that you cannot use anything that's ferric or magnetic. That includes it can't be done on people with pacemakers, cochlear implants, splinters, especially in the eye or the orbit, cerebral aneurysm clips, cardiac defibrillators, pacemaking wires, internal electrodes, all sorts of metal devices that will cause people discomfort or potential damage if they're in an MRI high magnetic field. A lot of the driving force between developing new technologies, such as non-ferric cerebral aneurysm clips, is an actual next step to make sure that MRIs are more accessible because of previous surgeries ruling people out of having that as an option of treatment or diagnosis. When you look at ultrasound, this is a fast-moving field as well. Ultrasound is going to be using high sound image so that it doesn't use any form of ionizing radiation. It's completely non-invasive, and it's much, much cheaper than any of the other imaging formats. It can be performed right at the bedside of an entirely sick patient, wheeled in and out of a room very easily. And it produces real-time images that now has the capacity to add that fourth dimension of time back into the diagnostic tool. Some of the disadvantages of it is that it's going to be not quite as clear as a CT or an MRI scan. It will produce shadowing on dense structures such as bone. It's because you get a sound shadow behind it. And it's very, very operator dependent, though this is starting to change with the advancement of computer technology as well, and the different algorithms being predetermined by the software as opposed to having to be interpreted and manipulated by the operator. So here you can see an ultrasound rendered baby. So this is surface rendering from just sound itself. And then the actual baby, after it's come out, you can see the resemblance is quite astonishing, other than the hat, of course, which I'm sure they put on after it came out. This concludes the foundations of imaging. In our next section, we'll look at imaging of the upper limb.